Good morning. This is the BLAINESWORLD Show, heard each week on, or seen each week on Facebook, YouTube, LinkedIn. Will soon be up on podcasts as well. And I'm your host, Blaine Greenfield, here in my Zoom studio in lovely downtown Fairview, North Carolina. Each week we focus on the Asheville theater scene, as well as on positive news and information about people and organizations in both Western North Carolina and throughout the country. And to that end, it's my pleasure to introduce my guest today, and she is Sandy Howard, a psychiatric nurse practitioner. And welcome aboard, Sandy. You can wave to all
Hi.
your friends. Everybody's watching. She beat me to it. That's Sandy Howard. Sandy is a friend of mine, but she's also a graduate of Vanderbilt University, practicing psychiatry in North Carolina for almost 20 years in outpatient and inpatient hospital settings for acute psychiatric conditions and detoxification, and also in many types of community mental health settings and private practice. And the question, Sandy, I always ask a guest the first time I have them on the show to talk about a particular thing they do is in terms of getting into this whole field, where did you grow up as a kid?
I grew up in Connecticut.
Okay. And when you were a little girl growing up in Connecticut, did you always know you wanted to be a psychiatric nurse?
No,
Okay.
the thought never entered my mind.
When did the thought first enter your mind?
Well, I can tell you I have an uncle that's a doctor, a physician, and I have a couple of nurse practitioners in my family. But when I grew up, that was before there even was nurse practitioners. So I went back to school later in life, in my 30s, and I kind of found my way to it.
To be a nurse
To,
practitioner.
to
But
be to become a nurse and then a nurse practitioner. I was actually in the health and fitness business, so I was very interested in the body. I went back to college to become a physical therapist. And the school that I was at, after a year, physical therapy was changing, and you had to have a master's degree to become a physical therapist. So I decided that I was really liking my biology and anatomy classes, and um, where the school I was at had a really good. It was Tennessee State University, and I lived in Nashville, Tennessee at the time, and they had a really fantastic Bachelor of Science of Nursing program. And so I switched majors and then quickly decided that I wanted to become a nurse practitioner and set my sights on Vanderbilt.
and so how do you then focus in on the field of psychiatry?
So when I was in school, there weren't a lot of, usually you became a family nurse practitioner because you could practice. It's kind of like studying general medicine and then deciding to go into a specialty. So when I came out of school, you did not have to have a specific certification or degree as a psychiatric nurse practitioner. You just got into it. And my interests when I came out of school were psychiatry and cardiology, believe it or not. And so my first job was in psychiatry in rural northwestern North Carolina. And I did leave psychiatry for a couple of years, and I worked with a very big internal medicine practice in Asheville called Carolina Internal Medicine, which at the time had 10 physicians. And I did their emergency medicine and also psychiatry for them before I went back full time into psychiatry. And, it served me well because when I worked at the highest level of care for psychiatry, I worked for many years for Haywood Regional Medical Center and working on their psychiatric unit. I was their lead psychiatric provider for several years, and doing emergency evaluations all throughout the hospital. Also, that was around the time when psychiatric holding areas were becoming big in the emergency departments because the emergency physicians, they didn't know what to do with psychiatric patients or somebody that came in and they were detoxing from alcohol or from drugs. So it was, I loved all that. It was great. I loved my time doing that.
And talk about something that a lot of folks don't realize, unfortunately, but when they hear the term, nurse practitioner or specifically practitioner, and I've
Mhm.
gotten to be very impressed with the level of care I get from practitioners. Describe what that is then, as opposed to being a straight psychiatrist or a straight whatever, to be a practitioner. What is that?
Sure. So a nurse practitioner, so we are all registered nurses. You do have to become a registered nurse. When people go to their doctor's office or to the hospital and you hear the term nurse, a lot of times you're not really getting a nurse. So the first level is the certified CNA, certified nursing assistant. And here in North Carolina, you have to have experience. That's a certification that you get. You have to have that experience even before you get into a nursing program. And then a nursing program for a registered nurse or an RN is the majority of nurses have associate's degrees.
Right.
So that's a 2-year degree that you have to get that's very specific in order to sit for the NCLEX. And the NCLEX is the test that gets you your license as an RN. So so then there's a 4-year degree, the BSN, a Bachelor's of Science in Nursing. And that's what I got. And then sat for my NCLEX and then went on to my master's degree program. At the time, I went to Vanderbilt, there was not a doctorate program for nurse practitioners. There is now. It's a doctor of nurse practitioner. I like to call it Dr. Nurse.
Okay.
Um, it's so the master's program, it doesn't differentiate as far as what you can do. If I had a doctorate right now, I would still be doing the same job.
Except
Doing
you might be teaching. That'd be the one difference. That
no, you can teach
oh,
with your
right,
master's degree also, but let's say clinically speaking, I
right.
would be doing the same job. Now, a psychiatrist does go to medical school, and then you have to do your residency or what's called a fellowship for psychiatrists, and that actually takes 4 years. It's a different route, so to speak. It is more expensive. It's more years because you're talking 8 years versus 6 years. I guess a doctorate would be 7 years for a nurse practitioner now. But when we get out of school, as far as the job that we're doing is the same. Clinically speaking, you're seeing patients, you're prescribing medications, you might be doing therapy. There are some psychiatrists still that do therapy along with their patients, but that's very rare, I think, especially in Western North Carolina.
And the point I was trying to make, and I think you addressed it, is the fact that if you get to see a nurse practitioner or any practitioner in any field, you're getting excellent qualities, you're getting the same quality of service. And I've seen that even in terms of with my dermatologist, I'll see that, I guess, a practitioner and the person who helps me is fantastic. So it's
Sure. I think that, I have had people say to me, well, if I'm going to
right,
go, I've had family members say to me, if I'm going to go for my mental health, I want to shrink. I want a
right,
doctor,
yeah.
and because that's how they think in their mind. I think that there are excellent nurse practitioners, and then there are not so good nurse practitioners. There are excellent
I was going to say that,
psychiatrists
right.
and not very excellent psychiatrists. I think that it depends on the individual. A big key part of it is experience. And, was I good at this job, or was I as good at this job the first year or 3 years that I came out of school? I hope I wasn't. I hope that I'm much better now. Experience is really, really key. And now today, there are actual psychiatric mental health nurse practitioners, a specific degree that you go for as a nurse practitioner. And I would say that that degree emphasizes, instead of emphasizing general medicine, it emphasizes psychiatric medicine, as far as psychotropic medications, and therapy.
And let's talk a little bit then, Sandy, that if somebody needs a psychiatric nurse practitioner,
Mhm.
um, why do they see you?
Because they need medications.
Okay,
Either they're already on medications or they think they need medications for something. And so, I prescribe medications. So, what we refer to as psychotropic medications, antidepressants, mood stabilizers, anxiolytics, which are for anxiety, things like that.
because am I correct? Many times a doctor will even say to see a psychiatric nurse practitioner, even though he or she knows something about the field, but you know a lot more than they do. So is that typically what happens, that you'll sometimes be referred to by even a doctor?
Sure. Yeah, that can happen from primary care providers. I think there are a lot of primary care providers that they can prescribe an antidepressant or different things like that. They might get frustrated when the patient is not getting better or they get worse, and then they'll refer them to psychiatry. Whether it's a psychiatrist or nurse practitioner, and physicians assistants, PAs, also specialize in psychiatry too. There are some.
Because the other problem, not with all doctors, I guess, but several, is that they prescribe, as you said, medicine, but they're not the real experts in terms of how the medicine interacts with other medicines. In other words, and I find that, I don't say a problem with doctors, but they look up something, they prescribe something, and it may help some people, but not everybody, because they're not considering, I guess, the whole gamut of drug interactions, and that's where you come into play.
Right. And it's not just about drug interactions. Except I do have a pet peeve about that. I think anybody who prescribes any medication better know exactly what their patient is on,
Well,
and anybody can look up interactions, but you're right, they don't always. But I think it's about knowing the different mental health disorders, all the medical research, scientific research around what's going on with the brain. We know that there's different types of mood disorders. There's unipolar depression and there's bipolar depression. Well, if you give somebody whose brain is really bipolar depression and you give them an antidepressant, which is more for unipolar depression, you could flip them into mania. You could make them much worse, or they just might not get better. So knowing these things and what happens to the brain is really important, and that's where a primary care provider, they have to know a lot of things. There's my primary care provider, Elizabeth Torden, I'm going to give her a shout out. She's wonderful. She's wonderful, and she goes from soup to nuts. But she absolutely refers people out, whether it's psychiatry or whatever the case may be, for your liver, your kidneys, your stomach. But I think that being aware of that as a provider, that if you prescribe a medication, the person might have a bad reaction to it. But I think that's true of any medication. You could take a blood pressure medication and have a
right.
bad reaction to it.
Let's talk also about one of the things that I think makes you a little bit unique or different, has to do with the way the whole, I guess, practice has changed over the years, and especially with COVID, that it used to be, correct me if I'm wrong, you wanted to you wanted to get a prescription or whatnot, you had to see the doctor, and now, or the nurse practitioner, and now that's changed, I guess, especially over the last couple of years. How has that been for you?
So yeah, you're speaking of with telehealth.
Right, yeah.
Right. So I was doing telehealth before it was cool, pre-pandemic, and because there's such a great need here in Western North Carolina for psychiatric providers, period, and the rural counties really suffer. And when I first started practicing psychiatry here in Western North Carolina back in 2003, we didn't have enough then, and we still don't have enough. So we used telepsychiatry way back then, but it was done differently. You were at your clinic and you were beaming out with all of this equipment, which was huge back then, to a rural county. So, I might be in Haywood County and the patient might be in Swain County, something like that. But you were still doing it from a clinic, and you had this whole team of people that helped you to set everything up, and you were ready to go. With the pandemic, right before the pandemic, I was already doing telepsychiatry from my home office and through Zoom or whatever HIPAA compliant app, that I was using then. It changed overnight. For me in March of 2020, I was seeing people. I would say half of my week was seeing patients in person, and half of my week was doing this, on the screen, so to speak. And then it changed overnight. I think it was March 13th or March 15th, when it all became telepsychiatry, telehealth. And yeah, that changed everything. For 2 solid years, probably a little over 2 years, I didn't see a patient in person. And then when I went back to seeing some people in person, that was just as strange, making that transition back to seeing people in person. The vast majority of people still want to do telehealth. I think that psychiatry is probably the best uh, uh, part of medicine out there that's really tailored for telehealth, because it's not like I have to see a rash on your body,
Right.
or feel you or touch you to do psychiatry. There are things that I missed, especially with people with severe and persistent mental health disorders. So, thought disorders like schizophrenia, seeing a patient that's actively psychotic, being able to see them up close, to be able to smell them, how's their hygiene, um, seeing them, their internal distractions. It took some time and a learning curve to be able to do that over Zoom. Of course, I can't smell them over Zoom, but I'm always able to usually ask staff members, with the community mental health organizations, how were they today? Do you think they took a shower? To get what we call collateral information to help with the patient. So, and we have, and this is going on all throughout the country. We have people who have very severe and persistent mental illnesses that are roaming our streets. We know that the homeless population is full of people with mental health issues, whether it's something like schizophrenia, a thought disorder, or a severe post-traumatic stress disorder. And our community mental health agencies are trying to help those people.
As you're talking, I'm thinking another big advantage, though, be able to do this screen to screen, is that some people just don't want to come in, or it's very hard for them transportation wise, or it's a lot easier if they have access to do this at home and take a lot less time. And some people, I would imagine, are even more receptive to talking on this. It's, I guess, less personal. And so there are some advantages I see.
Absolutely. I'm glad you brought that up. When I started to see some people by telehealth who I always saw in person, and they kind of blossomed on telehealth. They talked more easily, because for a long time they didn't have to go anywhere. They did it from home.
Right.
And that was really helpful for people with lots of anxiety, social anxiety, agoraphobia, things like that, or folks who had a lot of physical comorbidities in wheelchairs, that it was just difficult for them to get out of their home. And you did see that. And then on the flip side of that was, if I saw somebody that was actively psychotic, they were kind of, like looking, and they they wanted to know it. I felt badly at times that it actually might feed into their psychosis because they're seeing me on a screen. But but I think for the most part, it was a good thing that a lot of people could actually talk more easily. Kind of bringing the conversation back to my private practice now, I find that most people, even when they might make the appointment and say they want to be seen in person, and at the last moment they want to do it by Zoom. And
Go ahead. I'm sorry.
I have a HIPAA compliant Zoom platform. You can't just do normal Zoom or FaceTime and see a patient because you're violating their privacy. You have to make sure it's a encrypted type of thing.
To talk about helping other people also, for example, who have a problem with alcohol. Can you help people with alcohol and drug problems as well?
Right. So, yes. So, part of what I'm an expert at is in recovery, in helping people, especially once they've maybe professionally detoxed or they're coming out of a program. So, when people let's say they start at a professional detox, maybe it's heroin or pain pills or alcohol, and they go into an inpatient detoxification unit, and usually that's between 4 and 7 days, come off of the drugs or the alcohol, and then they go into a step down program, hopefully. So that would maybe be a residential program, or they might go to a state program, which is we've got one here in Black Mountain, ADAC. And they're only going to stay probably 2 weeks for their rehab. If you go into a private rehab, and there's many of them here in the Asheville area, it's going to be at least a 30-day program. So people usually stay anywhere from 30 to 60 days. Then they leave and they might go to a sober living program. We used to call them halfway houses. Now they're called sober living. And then they step down to what's called a substance abuse intensive outpatient treatment. And that's usually 3 days a week for 3 hours at a time. And they have people going to meetings, NA or AA meetings every day, and you have a therapist. And that usually lasts anywhere from probably 6 weeks to 12 weeks. It depends on the individual, what their needs are, if they're having any relapses, things like that. So with drug and alcohol abuse situations or dependency, you want to get as much support as you can. And if you relapse, then you want to kind of go backwards and get more support and keep working the program that way. So many of my patients now, they're to the point where they might have completed all those programs. They may have been, let's say, alcohol use disorder. They may have been sober for years, maybe decades, and then something happened. Maybe they thought they could go back to drinking again, or a trauma happened to them or in their lives, and they relapse and they start drinking again, and they get a DUI, and okay, there's a problem again. And then, they detox, they go through the steps again, and then they're out on their own. But they might be on medications. They might have a dual diagnosis. That would mean you don't just have alcohol use disorder or substance use disorder. You also have an underlying mental health issue that you're on medications for. So, and they still need those medications, so they need someone to prescribe them. So that's where I come into play.
Okay. Now, also, Sandy, if you can, as we're talking about it, show that one slide, if you would, to talk about your practice. You can just point that up. In terms of, if folks want to get in touch with you, Sandy, the best bet, we'll see it in a second, is to contact you through, so it's Mountain Mental Health and Wellness. That's the name of the business?
Right, Mountain Mental Health and Wellness.
Okay.
And the website is .com, all one word, Mountain Mental Health and Wellness.com.
Okay. And so, and you have, if people can see it, or I'll read it in case they can't see it, they're listening to it. The phone number is 828-408-0432. That's 828-408-0432. to reach Sandy Howard. I'll ask you to also just highlight the initials after your name are
Sure,
MP is
nurse practitioner. BC is board certified.
okay.
So, and in order to practice in North Carolina, you must be board certified.
Okay. So best way to reach Sandy Howard, as indicated, is through this website, the phone number, in person, or telepsychiatry available. Sandy, you can get out of that for a second. Come on back to where you were without the screen, without that picture. So
Is it okay if you scroll down
yeah. Okay.
on
Great.
this website, and I'm on Facebook, LinkedIn, TikTok. I also have a link because I'm in a band with my wife, Deep River, and you can go to this link and click on our virtual videos. Here's Psychology Today. I'm verified on Psychology Today. That's a big website that has psychiatrists, nurse practitioners, and therapists for people to find a provider. And if you scroll all the way down here, you can send me an email if you want to. I'm always willing to do a free consultation. And
And
I know you've already said that phone number, 828-408-0432.
well, Sandy, go up too, because I wanted to point out one other thing that you're involved in, and that's what's the Mend Collective. And
Yes, I'm going to
explain what
click.
that is, if you would,
Okay,
please.
I'm going to click. I partner with the Mend Collective. I'm going to click on their link and it's going to bring up their website. And this is a group of therapists. I'm going to bring them up and we share an office. So Andy Macon, Josh Stone, Jess Edmonds, and Abby Hearn. And you see me there on their website. You can go to their website, click on whoever you want to learn about, and you can read about them, how they practice, and their philosophy with therapy.
Let me ask you this, Sandy. In terms of choosing a therapist or a nurse practitioner, what should people do in terms of what are the things they look for, or how do they make that decision?
Well, I think, with a therapist, I would say go in with an agenda. So if you're looking for trauma-based care, then you want a therapist that has experience with that. There's specific types of therapies. Um, EMDR is a type of therapy that's used for people with trauma, but there are other types also. All of these therapists that I have up right now, they're also specialists in recovery for alcohol disorder, use disorder, and substance use disorder, as well as doing, they might do couples therapy, individual therapy, trauma focused, lots of different things. And then there's also Abby down here. I don't want to forget her.
So the advantage, I guess, to working with these folks and you as well is that they have tools at their hand at their disposal, and some of them do involve pharmaceuticals, or drugs that can be helpful to people.
Right. So none of them, so they're therapists, so they don't prescribe medications, and that's where I come in. So if they have a patient that either needs meds or is already on medications and they need them to be managed, that's where I would come in. Or if they have patients who, or a therapist usually calls their patient a client, where in the medical world we call them patients. Um, or if they have someone that they think might could benefit from medication, somebody struggling with depression or trauma or whatever, that they would refer them to me. Or if I have a patient that doesn't have a therapist, I would refer to them.
So it's kind of nice. So it's like what's impressive, they even call it our team. So in terms of
Yes.
working with you, it becomes a team approach as opposed to just, everybody doing it on their own.
Right, right. And here I am doing my music therapy, singing my heart out.
Okay, and then just back up a little bit, just
Ooh,
back down a little
sorry.
bit. I just want to show too, if you go to the website, you'll be kind of impressed, I know I was, if you'll see the areas that Sandy sort of areas of expertise. If you can just highlight some of those. If you work with Sandy Howard, just go down a little bit further. I saw a list of things you were involved in. Learn more.
Oh, sure. And you mean on my website?
Yeah, I saw something where it talked about the things you can help people with, Sandy.
Yes. So let me
Yeah,
get
here it is. Right,
that
go
here.
right up a little higher. We lost
Yeah,
it.
right here. I've got a list of things. So if you go on my
Exactly.
website,
Yeah.
right. And so, attention deficit disorder, mood disorders, like I talked about earlier, whether it's unipolar or bipolar, anxiety disorders, there's different types of anxiety disorders, social anxiety, trauma can cause a lot of anxiety, post-traumatic stress disorder, obsessive compulsive disorder. The list goes on. On my website, I'm linked in either with the National Institutes of Mental Health or the Mayo Clinic. So let's say you think you have intermittent explosive disorder. You click on that and it will bring you
Cool.
to explain about what it is. Either, from the national, this one's from the Mayo Clinic. So you can do that and do some research that way. I also prescribe what's called buprenorphine. A lot of people know it as Suboxone treatment. It's a medication assisted treatment for people with opioid use disorder. And so you can click on this and it explains what buprenorphine is. And this is from the Substance Abuse and Mental Health Services Administration. So you have to have a special license, DEA license to prescribe buprenorphine.
Sandy, two final questions. One having to do with kind of most people in general is how does somebody know when they should be getting help or seeking help? In other words,
Sure.
is
And,
there
and I think that, mental health, there's a lot of natural things that we can do to help our own mental health. Diet, eating a good diet, lots of vegetables, fruit, staying away from white flour, white sugar. We know that those things cause inflammation in the body. Exercise, we know that aerobic exercise, especially, so anything that gets your heart rate up, you're huffing and puffing. When they do the research, 1 hour, 5 days a week of aerobic exercise can work as good as an antidepressant can for depression, for unipolar depression. We know that getting regular sleep, 7 to 8 hours of sleep every night is really important. Getting out into nature. So, what I do in prescribing medications affect our neurotransmitters in our brains. But a lot of things affect our neurotransmitters. If I eat a good meal or I walk outside into nature, that makes my dopamine go up in my brain. And dopamine, that's the feel good transmitter, neurotransmitter. It makes us feel good. Think about when people abuse stimulants like methamphetamines or cocaine, that just, blows the dopamine neurotransmitters through the roof. But we can help ourselves by going out into nature, exercising in nature, taking a walk outside. If there's a body of water nearby, we know that the dopamine levels go up even higher. Um, Doing things that are pleasurable to us. Help our brains. So if you're doing all those things and
good
you're
point?
still struggling, let's say, clinical depression. So everybody uses the word depressed all the time. I'm depressed today. And everybody has a bad day. We all, our mood goes up and down, just like our blood pressure and our heart rate goes up and down. And we can have a bad day. We could have a bad couple of days. Heck, sometimes you have a bad week, right? But clinical depression is when you wake up, that cloud is over you. I see that I'm getting dark. I'm going to let some light in here.
Okay.
That cloud is over you. And, you don't have to feel like you want to kill yourself to be clinically depressed, but sometimes that's a part of it. Thinking passively, if I go to sleep and I don't wake up again, I'd be okay with that. Or maybe lots of thoughts about death, maybe not killing yourself, but just thoughts, lots of thoughts about death. You keep obsessing of it over it in your brain. It's hard to get out of bed, even though you might not be able to sleep at night, but in the morning it's hard to get out of bed. You don't really want to take a shower. You're not paying attention to your hygiene like you used to. You go to work. Maybe you can go to work or go to school, but you're having a hard time completing the tasks that you need to do. You're not reaching out to friends and family in the way you used to. You're isolating yourself. So you feel this dark cloud over you. You might get distracted for an hour or two or three, but then it's right back again. And that's happening day after day for 2 weeks or longer. That's really the criteria for clinical depression. And when that happens, you want to get help. You want to reach out to a therapist or to someone like myself that prescribes medications, or to your primary care provider. You can talk to them first. Because if you are clinically depressed, you can get better on your own. This might last for a few weeks or a few months, and then something happens and you get better. But what happens with your brain, it's called the 50, 70, 90% rule. Once you've had an episode of clinical depression and it doesn't get treated, you are then at a 50% higher risk of having another episode of clinical depression. And the next episode is going to be worse than the first episode, then 70% higher, then 90% higher. So that's why getting treatment is so important. I wish that the medications that I prescribed, I wish we had better antidepressants. But sometimes they help people. They don't, some people don't get helped by the medication, but I think that the vast majority of people, we do find something that helps them. And then treatment's not just about medication, it's also about therapy. It's about learning skills, so that you can better take care of yourself. Speaking of therapy, cognitive behavioral therapy, or CBT, is about self-soothing, self-calming, mindfulness, being in the moment, and learning skills to help yourself. So it's a whole village of different things. It's not a one-stop shop, so to speak, to just get medication.
And I like what you said, Sandy. It's kind of a good tip off. If somebody finds themselves in this fog or this deep funk, whatever, beyond, a day, 2 days, couple days, when you feel that way, get help. And I just mentioned one other thing you forgot to mention. You mentioned all these good things folks can do. You forgot the most important thing is come see Deep River.
Come see Deep River. Music,
Right.
right? We know that music really helps the
And,
brain.
and,
Yeah, Deep River.
and Sandy's and Deep River, they're the best. Sandy, to recap, just if folks want to get in touch with you for any things we talked about or for anything involving psychiatry in general, best thing, the website you see up there, you see Sandy's phone number, left-hand number. If you're not watching, it's 828-408-0432. And once again, Sandy, the website?
The website is mountainmentalhealthandwellness.com. And I do want to mention that I am LGBTQAI friendly.
Okay.
And that's why I have the little symbol up there, the kind of, it's kind of like the pride rainbow there with love.
Oh,
Um,
cool. Okay. I see it. Yeah.
yeah,
And anyway, I'd like to thank you for being my guest on this edition of Blaine's World podcast. Hopefully, we'll see you in person sometime in the next couple of years and even better in concert. Sandy, as always, a pleasure.
thank you, Blaine. Thank you so much for having me on.
Okay.